Hi everyone and welcome to The Pulse, the interviews at TCT Middle East here in Riyadh. The Congress is just over and it's my great pleasure to welcome Professor Akiko Maehara from Columbia University in New York, United States. And she's also the director of the Intracoronary Imaging Cath Lab and Trials at CRF. So it's great to meet you. Professor Maehara, we want to talk about three aspects on IVUS and bifurcation PCI. And to understand life and medicine, you have to look backwards, but you have to live forwards and to look into the future. Maybe look a little bit back. Looking at this Congress, we had a lot of sessions on IVUS-based bifurcation stenting, IVUS-based left main stenting. If you look back, what changed in the last 12 months according to guidelines and trials which are changing practical fields and how people adopt IVUS and bifurcation PCI?
So I think like the last year, ESC bringing to the class 1, and this year, HACC going to be the class 1. I see a lot of movement in the United States, and people want to learn, and they feel I must do the imaging. That I hear many places. And that's how I see. And in terms of that session, which we see today and yesterday, it's really, whenever you see the imaging, you will see what's happening really inside. By angio, you may not know, and many times we see the supplies. So then we have to adapt what's happening inside based on the observation. So I think even myself, always when I see the new case, I learn new thing. That's how the intravascular imaging tells us.
Yeah, I think it's very important because we have a recommendation by the European guidelines, which is 1A for dedicated scenarios, which is bifurcation PCI, left main and long lesions. Is it enough, Professor Maehara, to have these three special topics, or do you see different fields, or should be every PCI done IVUS guided or OCT guided?
So I think that this is really the definition, what is a complex PCI, right? But even though you think that's super simple type A lesion, but when you close, you may have trouble. And when we see the IVUS, we may have different aspects, like the look simple lesion, but it was very eccentric, negative remodeling artery. That could be very difficult to open up nicely. So to me, what is the real importance of the complex lesion? The definition is imaging tells you this is really the complex lesion, or could be simple lesion. So without looking inside, we couldn't define what is what. But that's my honest opinion. But in general, I do agree, start with the bifurcation. Left main, long lesion is very makes sense. But also, recently we have much more data when we look into the calcified lesion, imaging guidance do better. So calcified lesion is important. And instantly stenosis, without knowing what's happening inside, we should not treat. That's very important. And CTO, almost impossible to treat. The CTO without the imaging, IVUS, that's very important. And osteo lesion we see today, it's truly osteo lesion, or we should extend to the left main. Those decisions is really based on the imaging. So not just like the so-called complex lesion, it's really more broad. But whatever you think looks complex, that's really the complex lesion to me.
Yeah, I think this is really important because there is no simple coronary angiogram, there is no simple case. We should keep it simple, but not simpler, right?
Yeah.
So, and according to this topic, let's switch a little bit to bifurcation PCI.
Yeah.
There's two fields. Some people saying, okay, we need to stent bifurcation stenting techniques, and EBC main study says, and the EBC consensus says, keep it simple, not too simple, but start upfront with provision. What is your takeaway for this?
I think both are true. But to me, what is important when we are talking the bifurcation lesion, what I learned based on the imaging is always the plaque continue to the main vessel. Meaning when we are talking the distal left main, 90% of the time, the plaque is left main to the LAD, always, no matter how it looks like angio. But circumflex ostem is a lot different, meaning sometimes continuous to the left main, and sometimes super clean as seen by angio, or sometimes very focal. So to me, what dictates to you what is the best strategy of the bifurcation stenting, side branch imaging is the most important. Knowing what's happening in the side branch that dictate what you should do. So I think if really significant side branch disease, I think start with the two-stent technique is the best. But what is the most appropriate criteria to say this is definitive two-stent technique? Actually, we didn't define good enough yet, but that's really based on the imaging in the side branch.
Yeah, super important. We have not to stick only to Medina classification, which is purely angiographic and not IVUS guided. Maybe we need a classification IVUS or OCT based, a new Medina 0.2 or whatever you call it. So very important. So let's look a little bit in the future. We had a great live case from Belgium showing an IVUS guided PCI with smart glasses. What is the future in the field of PCI? Maybe also about education and about teaching aspects.
I think there is a lot of hope. And I see so many AI in the imaging area, like the Boston having the Abbott Hub, and every company putting the measurement already. And additionally, they could register onto the angio. So for the operator, it's actually easy. You can see what is the morphology, what I should prepare, and what is my result. So that's almost going to be automatic. So that's help us to guide as well as standardize or algorithmic approach. And then teaching the young generation is much easier. So I think everybody try to adapt what is already available and then make it easy and then really concentrate your brain into the most key aspect of the procedure decision making. So I think the future is really AI is already here and making it even better and better. And then last step is we really have to adapt to use wisely and then choosing the best decision making.
I think this is a perfect summary. So at the moment right now, and I think we also need it in the future, is human intelligence. It will never get skipped by artificial intelligence. So not in my lifespan. But I think we have to adapt to modern techniques and what is available. And we have 1A recommendation to sum up for a chronic coronary syndrome, and we have a 1A given by the ACS guidelines, by the American guidelines for IVUS guided and OCT guided, image guided PCI. So and we have to use our techniques right on bifurcation PCI and in every PCI, even not bifurcation PCI. So it was my great pleasure to have you here as a super expert in the field, and stay tuned for other interviews of The Pulse and hopefully see you soon. Enjoy. Bye-bye.